everyone. I am Dr. Rana Mondal, one of the mentor at the StudyMEDIC. Welcome to our RR YouTube series. Today I am going to involve two important topics. These are the endometriosis and ovarian stimulation. Both are very important in your fertility aspects and also very much useful in your EFOG exam and also in EFRM exam. So I will be covering in this and in a single best answer and EMQ session. Here I will be discussing 10 high yielding SBS and 5 EMQs, which are only include the critical concepts and the most common things that are going to ask in your exam. So please try to answer them on your own first. What you can do is that you can pause the video here and try to answer it yourself before I start discussing any of the question. Now, first question is 32-year-old woman undergoing her first IVF cycle develops ovarian hyperstimulation syndrome. Which strategy is most effective in preventing OHSS in high-risk women? Please remember that in the ovarian stimulation, OHSS is the most important part from your examination point of view. The answer is um, that the GnRH antagonist protocol with GnRH agonist trigger is the most effective way of preventing OHSS. Please remember among all the protocols, all the methods that has been considered, which the most effective two ones is the GnRH antagonist protocol with GnRH agonist trigger followed by the freeze all strategy. And when you combine these two it's the highest effective and it has given the rise of OHS free clinic where in the IVF clinics where they routinely follow this antagonist protocol followed by freeze all strategy and then frozen embryo transfer. Now what happens is that in GnRH antagonist protocol you start the stimulation from day 2 or day 3 of your cycle and you start either with FSH or HMG from this day 2 and day 3 and continue around day 11 or 12 or till the follicles become mature. And around day 5 or day 6, if you're using a fixed protocol or in flexible protocol where you can add GnRH antagonist when the follicles becomes around 12 to 14 then you add GnRH antagonist and wait till the follicle grow until the 17 to 18 at least 3 follicles should be there grown at more than the 18 where you can provide the trigger injection which is GnRH agonist either in triptorelin um, or luprite or whatever any agonist that will produce the FSH and LH surge for follicular maturation. The important thing is that these surges are not long lasting, very short, very sharply decline, so that the corpus luteum formed after this cycle in this protocol are not very long lasting, their half-lives are very low, and so luteolysis of this corpus luteum begins very quickly. Usually within the 5 days they become destroyed. That's why OHSS risk become very much minimal in this type of protocol because the in corpus luteum gives the provide the sources of VEGF during the OHSS when happens, but when you provide in this type of protocol as the corpus luteum half-life becomes very much less, so the OHSS risk become very much minimal. Now coming to our next question. Which one of the following is recommended as first-line ovarian stimulation agent in IVF and ICSI? Please try to answer it on your own. Now, recombinant FSH, please remember the recombinant FSH is recommended as first-line stimulation agent. If not, the recombinant FSH produces a better result than HMG. Okay, both recombinant FSH and recombinant HMG gives you a similar kind of clinical pregnancy and live birth rate outcome. Clomiphene citrate gives a multifollicular development, but it does not produces as much as eggs as in HMG or FSH. So efficacy of HMG and FSH is much more higher, whereas Laterals produces only monofollicular development. Progesterone priming is not very effective in terms of producing high yielding eggs, number of eggs. Now, why recombinant FSH? Please remember that HMG can have very much batch to batch variability. Why? Because of this is the impurities in the HMGs are much higher, and they are extracted from the urinary sources usually. After that, you need to process it to form a highly purified HMG. But in the past around few decades, 2 decades ago, there is a high batch to batch variability in HMG due to presence of impurities. So that's why then the recombinant FSH is now becomes a drug of choice, because in recombinant FSH the purity levels are more and batch to batch consistency are very much maintained. That is why usually we choose recombinant FSH if patient is in normoresponders phase. So recombinant FSH has a least amount of purity and least batch to batch variability. So that is why it is usually chosen as a first line agent for ovarian stimulation. Now, coming to our next question, a 36-year-old with endometriosis and infertility is planned for IVF. Which approach maximizes the live birth rate? Now, please remember that the ESHRE guideline has stated that routinely surgeries are not required, but it may be indicated if endometrioma is more than 3 or 4 centimeter, or it is symptomatic, or it can affect the pathway of retrieving eggs during IVF when egg collection to be done. Now, I will divide this answer in a two phases actually. First, I will discuss what are the risks or and if you don't do anything to the endometrioma during ART, and what are the advantages if you don't do anything to the endometrioma at ART. Then I will become the risk and disadvantages of treatment of having surgery. So, if you remain the endometrioma intact, what happens in them? If you remain intact, first of all, if you're not doing anything, then the important thing is that you are not hampering the ovarian cortex at all. So there is a higher chances that you're not disturbing her ovarian reserve at all, because you're not damaging the ovarian cortex. So if the patient has a decreased ovarian reserve, you're not hampering it at all. The next one is that if you but the on the contrary, what are the complications of having endometrioma? There is a high chances that within the 1 to 2 years disease progressions are much more if the patient is in younger stage. If you remain the endometrioma, there's a high chances of having during IVF, if you are puncturing it through, and if certainly you have punctured the endometrium, there's a chances of having infection, and it can lead to peritonitis as well as chemical peritonitis. That's why ESHRE guidelines recommend that whenever you're doing egg collection in a patient with endometrioma, it is advised to give antibiotic to them. And moreover, if you keep the endometrioma present there, it increases the requirement of the dosage of the any ovarian stimulating agents, and also sometimes prolongs the duration of ovarian stimulating agent, so it becomes much more costlier. And when you are doing an egg collection, it sometimes becomes challenging, because it may sometimes occlude the pathway of needle that have to put for egg collection. Now, what are the pros and cons of having surgery during prior to the ART? First up is that surgery is a if you have a surgery, the it is important that your patient if patient has a symptoms, you need to have a surgery prior to that. it becomes a long-term pain relief for the patient. So you need to consider surgery, especially when it's less than 35 years or having a symptoms. So in these two cases, you do need to consider the surgery prior to the ART. On the contrary, the risks are that this has a surgical risk like bleeding, infection, visceral injuries, and here you have to have an incision or nick in the cortex area. So you do remove the endometrioma material. So there will be a damaging to the ovarian cortex, which can reduce the number of eggs, or sometimes can lead to the premature or surgical ovarian failure as well. So these are the risks of having surgery. Now, moving on to our next question. Which gonadotropin strategy supported by these ESHRE guidelines for the most normal responders? Dose individualization has to be done on AMH and interfollicular count basis on the risk of having OHSs and to optimize the outcome. Now, what few things before ovarian stimulation you need to be considered. Please remember that when you're doing the menstrual cycle has a few stages. Primordial stage, primary follicle, and then secondary follicles becomes antral follicles. These antral follicles are around 2 to 5 mm, and with these are visible on the your ultrasonography. These are not all visible. This is the you can see these antral follicles explicitly on the day 2 and day 3 of the menstrual cycle, and that is where it begins. And in normal process, what happens is that after antral follicle, the recruitment phase is over. It's around day 5 or day 6 when the level of FSH is usually high, and this is the window of recruitment. After that, only though that follicle which has the highest number of granulosa cells can have usually selected, and other becomes atretic, and the selected follicles becomes dominant follicle later on. Now, in this ovarian stimulation, what you would do is that you prolong the FSH window via providing the drugs, that is the other either HMG or FSH, and prolonging the recruitment phase of window. So not only one or two follicles become recruited, multiple antral follicles get recruited due to this. So that's why you have a multifollicular development during this period. Now, how to choose which drug? Two things you need to see, that the antral follicular count AMH, and also you need to see the patient age and BMI. That also very important to consider the dosage of the drug you want to give. Now, if the patient has a low AMH or low antral follicular count, if AMH is less than 0.5, it is considered as a poor ovarian responders, or antral follicular count less than 3, it is usually poor ovarian responders. In that cases, you usually use you can use either antagonist and agonist cycle. Other types are the flare protocol or short agonist protocols. These can also be used in a poor responders. Suboptimal responders are some things which a category which is between the normal responders and the poor responders. These are the patient who has a variable AMH of around 0.5 to 1, and follicular counts are between 4 to 9. So in this patient, often we use the GnRH antagonist protocol or agonist protocol depending on the patient. And usually the starting doses are around 225 to 300 depending on the BMI. Whereas in the poor responders are the level of the starting dose can go as up to as 300 to 450. In normal responders, patients are those who have an AMH of around 1.2 to 3.5, or antral follicular count 10 to 20 or 25. Here, usually according to the BMI, you need to put on in between 150 to 250 dose, And in the both GnRH antagonist protocol, agonist protocol has a similar result, but antagonist preferable as it is a more OHS free. In high responders like in PCOS, usually you have and AMH more than 3.5 and antral follicular count more than 20 or 25 or PCO ovaries. In this patient, try to have a low dose, starting dose, 1 less than 150. Of course, if the patient BMI is very high, you have to go with a higher dose in that cases. It is preferable to have an antagonist protocol with an agonist trigger and free sol strategy in such kind of women to prevent the risk of OHSS. Now, our next question is that role of pre-treatment with oral contraceptive before ovarian stimulation, does it have any effect? Please remember that the EFRE guideline has stated that the OCP pre-treatment may be used for scheduling, but it does not improve your either clinical pregnancy or live birth rate. So it does not have any impact on the efficacy of your ovarian stimulation. It only helps schedule your patients. Either you can postpone one cycle or even preferably after giving an oral contraceptive you can schedule her menstrual period on certain days or preferably clinic as well as when clinic is open you can do that and then you can start the ovarian stimulation. So only one purpose served by the oral contraceptive agent is that the scheduling. It does not pre-treatment with either estrogen, progesterone or combination before ovarian stimulation either in antagonist or agonist protocol is not recommended because it does not improve the efficacy and safety of any ovarian stimulation. Now, moving on to our next question. In women with endometriosis associated with infertility, which treatment is least effective for improving fertility? Least effective method is the medical suppression. GnRH agonist, and agonist or OCP, whatever you use, the medical suppression after the surgery delays conception and does not improve the fertility at all. And please remember that not only delays if the woman is an elderly aged woman, like in around 35 or 37 years, in those patients giving medical suppression, of course, it will delay the conception, and this period is vital for them because in this time they have already endometriosis and also they have a hastened process of reduction of number of eggs. So it is not tried to avoid in this category of patient giving uh, overall medical suppression at this time after surgery. Okay, these are the all drugs as recommended by the ESHRE guideline. You can go through this. I cannot cover all this mechanism and action and action and dosing, and these are very simple things, but you should know all these things. Yeah, sometimes in EMQ you may have some options of these drugs which to choose. Now, next question is that which strategy is optimal for luteal phase support in IVF? Luteal phase support is a very important. The most of the standard clinic and also the guidelines recommend that the vaginal progesterone is the standard recommended luteal phase support, and because it is much more simpler to take than the injectables. Now, I am going to discuss two things that you need to understand what happens in the luteal phase, especially in the frozen embryo transfer. In normal patients, after ovulation, the luteal phase begins where the secretory changes have starts, and they are here. Please remember, in luteal phase, both estrogen and progesterone increases due to the presence of the corpus luteum. So for luteal phase, both hormones are required and you can see this is the changes can begin. Usually if you are doing a fresh transfer you do the egg retrieval around 11 to 14 days and after you start the give the luteal phase support from the day of the egg retrieval and then continue till the day of your transfer accordingly day 3 or day 4 and then you can usually they usually give the vaginal progesterone from then to the day when you want to check for the pregnancy test, whether it is a positive or not. Now, frozen, if you are not doing the transfer on the same cycle, that is, you're not doing a fresh transfer, you're considering for a frozen embryo transfer. What you need to do? Frozen embryo transfer can be a two type. Either in one patient you want to have a ovulation or in a non-ovulatory cycle. Please remember that non-ovulatory does not mean the patient cannot have ovulation. It means that you are not doing an ovulation, you're not going to do the ovulation in that cycle. In that cycle, usually the hormone replacement therapies are used. You from the day 01 day period, you start them with an estrogen, and when the endometrial thickness becomes good enough, like around 11 millimeter to 14 millimeter, then you start the triple line endometrium with a 11 millimeter thickness or more, with zone 2 vascularity or more. Then you start the progesterone therapies from then date one, and according to the day of embryo transfer, you will keep on the progesterone. This is called the non-ovulatory cycle or hormone replacement therapy cycle progesterone supplementation for the luteal phase. And when you have an ovulatory cycle, that is you meant to have an ovulation in that woman. Please remember, either you can do a natural ovulation and then according to you will provide a luteal phase support or do the transfer. But please remember that the natural cycle, you need to know the day of ovulation. Either it can be done via follicular monitoring, or it can be done via the LH kit or any ovulatory kit agent through that. In modified natural cycle is somewhat you are modifying the natural cycle. How do you modify that? One key thing is that you start giving them the oral ovulatory agents to have an ovulation, and then when they have a mature follicle, you induce ACG or any other hormone to get rupture those follicles to enter the secretory phase or luteal phase of this patient and provide luteal phase support. Now, there are various luteal phase supporting agents are there. Either you can give an intramuscular, oral, vaginal, and vaginal progesterone tablet insert. These are the various forms are available. Please remember that the most common and old forms are the intramuscular forms, and often used to prefer a decade ago. Usually, intramuscular forms are the most common methods of post-luteal phase support after the embryo transfer. Intramuscular progesterone doses are around 25 to 50 mg, whereas vaginal progesterone, either usually an 8% vaginal progesterone or a 90 milligram vaginally once or twice daily has to be given. In terms of efficacy, there isn't any much difference between the intramuscular and vaginal form. Nowadays, subcutaneous form has been also become available. Oral micronized progesterone usually is around 200 mg. You have to give at least 3 times a day if you are considering it for luteal phase support. Now, oral micronized progesterone is now also considered to have a similar kind of efficacy with the vaginal progesterone. Now, in Lotus 2 trial, they have head-to-head compare between the oral and the vaginal progesterone, and it has given the initial hints of results that it has a similar kind of efficacy. Okay, so these are all the forms of progesterone. I hope you all guys know when to give the progesterone during the transfer. As I have already told you, in the fresh embryo transfer, you need to start the progesterone better. The ESHRE guideline recommend when you do an egg retrieval, from the evening of the day of egg retrieval, start giving the progesterone. And according to day of your embryo transfer, day 3 or 4, after embryo transfer, continuous luteal phase support as any of the method. Preferably is the vaginal progesterone method because it has simpler. It does not have complications like intramuscular injection, and you can give it on your own. That is the main advantage. Now, moving on to our next question. 29-year-old woman with a diminished ovarian reserve is undergoing IVF. which stimulation strategy is supported by the guideline. Now, it may be sometimes confusing. When I was very young, I was to get confused with this also. Why mild ovarian stimulation is sometimes preferable for the poor ovarian responders, even though have a very less number of eggs. Because and very high dose does not improve the number of eggs and does not improve the live birth rate. So that's why. What happens is that in the normal ovarian stimulation, you start in giving injection either from day one or day two for if you're doing an antagonist cycle, and then you collect the eggs and provide the embryo transfer. But in mild ovarian stimulation, our goal is to have a least number of eggs. You usually provide an oral ovulating agent, preferably clomiphene, and then what happens then when the recruitment phase has been stopped around day 6 or day 7, you have already the recruited follicles. The minimal number of recruited follicles has been gained. You can support their growth by giving a low dose of HMG or low dose of recombinant FSH to become mature. Now, why mild ovarian stimulation is important is that the concept behind it is that when you are giving a conventional IVF or not IVF or in any protocol, you are giving a multifollicular development of growth. Uh, it is that they are growing, but all the eggs you are getting in the poor ovarian responders patient are not the healthier eggs. So the even all the getting a good number of eggs, you're not having a good quality of embryo, or getting a good quality of embryo at the end. So it does not improving your live birth rate at all. Whereas in the mild IVF, you are having a selecting the more physiologically competent eggs. Although the number of eggs you are getting less, but the embryo formation rates remain same. And although you're using a minimal number of drugs, a minimal cost effective drugs, and you're getting a same quality of embryo, so you're getting a similar kind of live birth rate. So that's become the effectiveness of the mild ovarian stimulation or soft ovarian stimulation. Now, you should be familiar with these terminologies. The natural IVF cycles is that where you do not give any kind of drugs, and usually the single dominant follicle which is selected, or which usually select, you collect that follicle and do the IVF. And the not modified natural IVF cycle is also kind of similar, but here it is that you give the trigger injection up before collecting the egg. In the mild ovarian stimulation, usually with aim to have a 2 or 7 oocytes. Here usually what you start with a clomiphene citate on day 2 and day 3 onwards, and the after giving a 5 to 7 days of that, when the follicles has been recruited, the more physiologically competent follicles has been recruited, you give the supporting dose of HMG to sustain their growth, and when they have matured enough, you to provide the trigger injection and do the egg collection. So this is the concept of mild ovarian stimulation. Now moving on to our next question: which factor is strongly associated with the risk of OHSS? Please remember that there are several factors associated with the risk of HSS, but the most important one is that the high AMH and high antral follicular count are the strongest predictor of OHSS. Now I am going to go some basics here. What happens and why you have OHSS? Now, what happens that during the ovarian stimulation, you are giving a higher dose of gonadotropin. It produces the high level of estrogen, and there are multifollicular growth that itself are producing high level of estrogen. Now, when you do the egg collection, you are puncturing all of these follicles. You have collected the egg, but their granulosa cells remain, and which will transform into the large luteal cells cells, and the thicker cells will turn into the small luteal cells. These large luteal cells have a higher angiogenic activity. This multiple corpus luteum will have a higher angiogenic activity because they release a high number of vasoactive factors. VEGF factor is the most important, others are the interleukin 6 and 8. Now, as the numbers are more of corpus lutea, the risk of which are more because there is more amount of the accumulated amount of these vasogenic active compounds are present. These vasogenic active compounds, what it does is that it downstream the signaling of the VEGF receptor 2 that causes the changes in the actin fiber and rearrangement of the cathedrin molecules. That increases the capillary permeability or vascular permeability, leading to the third space fluid accumulation or third space fluid leakage, which will lead to the tissue edema or tissue edema. In the most common to have ascites is common, but when the ascites becomes very much severe, more than 1500, it becomes produces clinical significant. And sometimes ascites can cause a compression to the renal vein that will reduces the kidney perfusion and lead to the oliguria or anuria can sometimes lead to the. Also, it can produce a compression effect of the organs like portal vein, and liver perfusion can also be reduced, so liver dysfunctions begins. And you are having hypovolemia simultaneously due to the leakage of fluid into the third space, so hemoconcentrations begins, and when hemoconcentration is more than 45%, it becomes a stage 4 and can lead to the thromboembolic events. Please remember, hemoconcentration more than 50, 45% or having higher chances of having thromboembolic event, and if you have a thromboembolic event in those patients, the OHSS, you have to consider a critical care basis. So this is the basic mechanism of how the OHSS develops. Now, these are the factors, in most important things to consider of OHSS. PMI is a very important factor, but among all these, most important is the antral follicular count, and next one is the AMH. Women less than 30 years, BMI less than 22 is a high risk factor. Patient who have a previous OHS is a very high risk factor for um, for OHS. PCOS, especially the type 1, this is the phenotype A. PCOS are very high risk. If also the estrogen level before the day of trigger can give you predict the OHS as well. Ovarian volume more than 15 cc is also a predictive or OHSS. AMH more than 5 and antral follicular count more than 25. The body gives you high risk of having OHSS. Next question. A 34-year-old woman with a stage 3 endometriosis and infertility is considering IVF. Which statement is correct? Please remember that the IVF outcome in endometriosis is somewhat lower than the tubal infertility. Surgery is not universally beneficial, so surgery has to be individualized. That is a very important thing. What happens in the endometriosis is that there is a due to the there is some endometrial spots develop, especially from the beginning of the tubal end, that can produce a femoral adhesion, anatomical distortion of your tubo-ovarian relationship. So what happens is that the released eggs cannot be captured by the fallopian tube. And more important that not only the anatomical, they also disturbs your normal physiological. The chemokines released from the after ovulation to do the femoral egg pickup, it become dysregulated also in the endometriosis patient. Moreover, the myometrial peristalsis, which is usually begins from one of the cornu, usually the right cornu to the lower side, get distorted in the endometriosis patient. This is known as endometrial myometrium dysperistalsis. This can seen in all endometriosis patient as well. Moreover, then due to the presence of endometrioma and growing endometrioma produce a compressive effect or mechanical effect on the follicles on ovarian cortex that produces a hastening decrease of the number of eggs, so poor ovarian reserve becomes decreased. And not only that, they have some defective follicular genesis which may sometimes lead to the delayed ovulation or the long duration of the follicular growth. And also the oocyte qualities has reduced. In some patients it has been seen that when you see they have the endometrial patients has a more granular cytoplasm in the after the egg retrieval than the normal patients. So these are the few important things in these patients, and please remember that in even doing an ICSI in this type of oocyte does not improve fertilization. They have a poor fertilization even in IVF after IVF as well. And also during the implantation procedure they have altered or displaced endometrial receptivity, so due to the ectopic progesterone resistance in that patient developed and the altered transcription factors that are required for implantation process. Now, the ESHRE guideline has also recommended that please remember that for endometriosis stage 1 and stage 2, you can consider the intrauterine stimulation after ovarian stimulation. So, natural IUI is not recommended for the endometriosis patient with a stage 1 and stage 2. It is always IUI with the ovarian stimulation. For stage 3 and stage 4, it has seen that the ERT is produces a much more higher result than the surgery or than the having any other treatment. For those who having stage 3, stage 4, advanced maternal age more than 35, try to go with the direct IVF in those patients rather than waiting. Now moving on to our EMQ section. So this is our question. Try to pause it here, the video, and try to answer all the three scenarios on your own and then check it. Now, I'm going to move on here. The first one is that scenario is that the 27-year-old with a PCO patient is with IVF with a very high estradiol level. What is the safest trigger to avoid OHSS for this patient? Now, these all are the methods of preventing of OHS have been given to you. Now, which one is the safest? Please remember that I have already discussed this. The GnRH agonist triggered in an antagonist protocol is the safest way and most effective, most high-yielding strategy to prevent the risk of OHSS. Now, what is coasting? Coasting is that when you are doing in a high risk patient or patient who has a high risk of having OHS, you're doing an ovarian stimulation when the follicles have grown enough, like on day 7 or day 3 you have seen that multifollicular has been developed, and she has a high risk of ages or have an estrogen level more than 4000 already on day 3 day 9, then what you can do, you can reduce the dose or stop the giving and supportive HMG or any other ovulatory agent, stimulatory agent to them, and produce a natural course of growth without providing the dosage. This can sometimes reduces the risk of OHS. This is known as coasting. How the free sol strategy affects? Because free sol strategy effects are effective because you are not giving a transfer and providing luteolactic activity, so there is no progesterone support or HCG supports are there, so corpus luteal become decreased very quickly. And the late OHSs, which are the OHSs can happen after the pregnancy arrives, is usually happens after fresh embryo transfer. If you are doing a frozen embryo transfer policy, it nullifies that also. Now, dopamine agonist cabergoline, how it's effective? Cabergoline have anti-VEGF activities. As we have already told you that during the OHSS, the VEGF factor activities becomes much more, which increases the capillary permeability. Dopamine agonist can be cabergoline work on that way. Now, moving to our next scenario is that a 30-year-old woman at very high risk of OHSS after egg retrieval. What is the best embryo transfer strategy? Yes, the free fall strategy policy. Next scenario is a PCOS woman starting a stimulation protocol. What is the baseline protocol to reduce risk of OHSS? Yeah, it is a GnRH antagonist protocols. These are very simple but often asked in your exam. Uh, These are the OHSS prevention strategies are there. First is the ovarian, what you can do during the ovarian stimulation. The thing you can do the ovarian stimulation is that the number one is the GnRH antagonist protocol with GnRH agonist trigger. Delay starting the FSH can have either you can do an in vitro maturations. In vitro maturations are the thing newer thing, but you have to have a competent IVF laboratory to have an in vitro maturation. In this, what immature follicles around 9 mm, 7 to 9 mm follicles are has collected, and you have an immature oocyte that in laboratory you grow that oocyte and do the fertilization with the partner sperm, and then the produced embryo you're going to transfer. This is known as an in vitro maturation. Costing I have already discussed. Now, reduction of the follicles is the second thing. How to do that reduction of follicles? The you are not only during the egg collection procedure, you're not only collecting the matured follicles one, or the dominant follicles one. The ESHRE guideline recommends that those who have a high risk of having a OHSS, even the less than 10 mm, that's the non-dominant follicle, you do the puncturing for this patient and aspirate it to prevent the risk of OHSS. Now, what you can do the triggering method, alter triggering, you of course you can do the GnRH agonist trigger. If you are doing an antagonist cycle, you need to avoid HCG trigger. Okay, that is a very high term because HCG also increases the capillary permeability and have a superimposed function, and moreover HCG prolongs the life of the corpus luteals that are formed, so there is a higher chance of having OHSS. Recombinant HCG LLH has to be used instead of HCG. In luteal phase support, you can do a elective cryopreservation, that is doing a fresh frozen transfer, and luteal phase should be without HCG support. That is the most important thing to prevent OHSS in luteal phase. Now, moving on to our next question, that is MQ2. A 32-year-old woman with a normal ovarian reserve undergoing IVF, which gonadotropin is recommended in the first line? Yeah, it is a recombinant FSH because it has a very reduced batch-to-batch variability. 38-year-old woman with a poor ovarian reserve, first-line oral ovulating drug for IUI. Please remember this is a poor ovarian reserve patient. Which one is the first line drug? Yeah, it is a clomiphene citrate, not letrozole. The next one is a woman with a PCOS not ovulating on clomiphene. What is the next base oral agent? This is a PCOS patient. In this patient, you can give a letrozole for an ovarian stimulation. Now, what ESHRE guideline says about the stimulation and association of safety and efficacy? Please remember that the use of recombinant FSH or HMG are equally recommended. The clinical outcome and live birth rate outcome does not make difference with a recombinant FSH and HMG. What make it difference is that the recombinant FSH has a more batch to batch consistency. That's why we much more prefer the FSH. Both recombinant FSH or purified FSH in agonist protocol are equally recommended. Okay, the use of recombinant LH or recombinant FSH for ovarian stimulation are not recommended. For these are the newer drug which has a combination of both LH activity and FSH activity, and they are very highly costly, like Pargoveris. varies, but they are not recommended at moment because it does not have a proven clean meta-analysis that provide a higher pregnancy rate. Right? Please remember that for poor ovarian responders patients, it is always preferred to have a drug with an LH containing activity to have ovarian stimulation because they have a very low number of LH, which is very important for these patients also. Now, please remember that for the second scenario question that I have asked you guys, letrozole is probably not recommended as a substitute of gonadotropin in poor ovarian responders. For the ESHRE guideline says that the letrozole is better to avoid patient with a poor ovarian responders, and should not be a substitute for gonadotropin in poor ovarian responders. If you have to use an oral ovulating agent in a poor responders, that has to be an clomiphene, not letrozole. Please remember this point. That's why I have already asked you this simple question that has been asked in multiple times in the EFRM exam as well. And also I already told you during the mild ovarian stimulation why you use the clomiphene rather than having a letrozole also. Now, moving on to our next scenario. This is on the basis of the luteal phase support. Try to answer it on your own. Now, first scenario says that the standard luteal phase support in an IVF cycle. What is that? It's a vaginal progesterone. A patient develop a severe risk of OHSS after the trigger. Now, which luteal phase support need to avoid? To always avoid ACG in this kind of patient because ACG will prolong the half-life of the corpus luteum and prolong the effectiveness of the VEGF, and capillary permeability will be remain intact for a prolonged period, and so fluid transduction will become for prolonged period. Now, patient with an recurrent implantation failure after IVF, which luteal phase support option may be considered? Please remember that the patient who have a recurrent implantation failure, oral dydrogesterone can be considered in those patients. Now, what ESHRE guideline says about this luteal phase support protocol? Well, of course, progesterone support has been recommended for luteal phase support after IVF and ICSI. And any now your route has to be judgmented on the basis of your clinical practice and individualization of the patient comfortability as well. Dosing of the progesterone is really based on the which route you're introducing it. Usually 50 mg for IM injection. For subcutaneous injection, progesterone 25 mg once daily subcutaneous. For vaginal, progesterone 90 micromilligram once daily vaginal progesterone gel. 200 mg 3 times a day for oral progesterone route. If you are using an capsule form or vaginal capsule insert, then the vaginal progesterone insert in capsule 100 mg 2 or 3 times daily dose to be continued. If you are giving a vaginal pressure, vaginal progesterone pressure should have a doses of around 400 mg. So all these varieties of progesterones are available. You need to know the drugs, the dosage, and the duration of these patients as well. Now, starting from the progesterone in the luteal phase support should be in the window between the evening of the day of oocyte retrieval. So, if we are considering a fresh embryo transfer and want to provide a luteal phase support to them for fresh embryo transfer, the ESHRE guidelines recommended that you start the progesterone by the evening of the day of egg retrieval. Now, progesterone for luteal phase support should be administered at least until the day of pregnancy test. So when you are doing to confirm the check the pregnancy, that is the beta HCG test you are doing either on the day 11 or day 14, depending on the day of where you are doing the embryo transfer, you need to continue your luteal phase support until that. Okay. So please remember these important things. Now moving on to our next scenario. Now, this is about, and this again I am emphasizing what is the risk. This is a very important part for your exam is the OHSS. You have to know these basic things that how to prevent the OHSS. This is the at least thing you have to know. Which is the best marker for predicting wages? It is the AMH. I have already told all you guys, which is a single best predictor for ovarian reserve for ovarian stimulation dose adjustment. Please remember the antral follicular count is becomes more important than AMH for the dose adjustment. Okay, or the starting dose. It becomes the antral follicular count is the most important thing. Now, which historical factors is critical for predicting polyvariant response among all the history things or historical things? Please remember if the patient has a previous history of uh, which urges it becomes the most important as a previous history of poor response, it becomes a more important thing. Also, you guys will be knowing the Bologna criteria for poor ovarian responders. They have included that one of that criteria is that they have a previous poor response, it should be considered as a poor ovarian responders. Predictor of wages are the of course the primary factors are the high basal age, young age less than 22 years, previous OHSS, PCO like ovaries, all these things, secondary factors like number of follicles, estrogen level before the day of trigger, their VEGF level, ECG giving or not, all these things. Now, moving on to our last EMQ, a 34-year-old with an stage 3 endometriosis, severe pelvic pain. What is the appropriate treatment for that? Please remember when you see that this pelvic pain or these things are present, any patient with the symptoms, you have to consider them for surgery. Excision of a deep excision should be considered for this endometrial excision should be considered for this type of patients. Next one, a 29-year-old with an 4 centimeter symptomatic endometrioma before IVF. What is indicated? Surgery, if it is in more than 3 centimeter, usually the endometrioma has to be excised. It will recommended, usually recommended, as it has been by ESHRE and also by the NICE guideline. A 30-year-old woman with a minimal endometriosis, infertility for 2 years, no pain. What is the suitable option? Now, if the duration is less than 2 years and minimal endometriosis means stage 1 or stage 1, so it is they are very much a good candidate for the ovarian stimulation with the IUI rather than having a surgery or any other thing. So this is the ESHRE guideline recommends about the pain management. Any patient, even with infertility, if they're having a symptoms like pain, offer them a pain relief management fast and give of course you need to individual preferences to have a pain management and according to their pain severity, either you can do a simple analgesic to hormonal therapy to surgical option for endometrium include cystectomy or drainage or triple P therapy, that is after drainage they have to ablate the material and then seal it. This is the method you can use to this is the more ovarian cortex protective or more ovarian reserve protective method. Other than for endometriosis lesion, excision is the treatment of choice. Of course, ablation you can do, but excision is the treatment of choice. Luna is no longer recommended, and for midline pace, you can offer a presacral neurectomy for this patient. For any patient who have a deep in DIE, deep infiltrating endometriosis, surgery is always preferred. Please remember that pre-operative hormonal therapy has no role. So before operation, do not offer any hormonal therapy. Post-operative hormonal therapy can be used to reduce the pain and prevent the recurrences, but it does not improve the fertility, and those who want to conceive, you can avoid that. Do not have an impact or negative impact, but this do not have a negative impact on the fertility. For those patients who are having an endometriosis and infertility, what to do? Of course, please remember that hormonal therapy has no role for this patient. Surgery is indicated only if certain conditions. For stage 2 and stage 1, you for endometriosis, you can consider ovarian stimulation and IUI. For stage 3 and stage 4, you have to go with an IVF. Now, when you need to consider surgery for these patients, if it is and stage 1 and stage 2, I have already told you, if they are having a pain and patient is a very young, so you can provide a surgery to have a pain relief and long-term pain relief for those patients. You can offer IUI and or if the pain is not any concern, you can offer them first. If it is a shorter duration, less than 2 years of infertility, and you can offer them ovarian stimulation and IUI. And for stage 3 and 4, IUI is not much effective because in this type of patient, tubal damages are usually often can be seen, so IUI are not much effective. And tubal-ovarian relationships are always distorted in this kind of patient, so IVF is the best method of choice for this type of patients. But even in that, do not, please remember, for stage 3 and stage 4 also, do not routinely offer surgery for any grade unless specifically symptoms are patient or patient wants to have it. If the symptoms of pain or anything are present, you can consider surgery. Other indications of considering surgery is that patient preference, there has a difficulty, your patient is undergoing an egg retrieval, there is a huge endometrioma that can impact, or the follicular monitoring, growth monitoring, or follicular impact, follicular growth, or can have an impact on the egg retrieval, then you may need to consider them for a surgery. And for endometriosis patient, please, you have both antagonist and agonist protocol has a similar kind of oocyte yielding and similar kind of live birth rate. Antibiotics need to give before the egg retrieval procedure. Please remember these important points. Now, so thank you for very much for attending this session. Uh, Please remember that in this short series, I have to only consider the high yielding in the past 5 years. What are the most important things to comes in your exam for EBCOG exam, or you can use this for your MRCOG as well as EFRN exams. And if you have any questions or any queries regarding anything, you can comment it below the video as well. So thank you very much.